Fertility Factor Fiction, our show where we talk to you about all things fertility, sometimes obstetrical, sometimes gynecologic, and try and bring you the best information we can to help you along on your journey. I am your host, Dr. Rahi Victory, a reproductive endocrinology and infertility specialist. I am board certified both in Canada and the US. So welcome aboard. Hope that you've had a great week so far. This is one of our first shows since we are officially moving to a Tuesday. Since the votes last time were always for a Tuesday show. So thank you for joining us. We will be having an interesting topic tonight, and I'll give you some background history on it. I was kind of flipping through Instagram to see basically which sites were good and what information was out there and what looked appropriate and what didn't and so on. So during that search, I found a post from an individual that had a master class, I love that part, on doing ovulation prediction or monitoring. And their test or their, not their test, but their scheme behind this was that you could tell from basal body temperature monitoring, cervical mucus, and my all-time favorite, the position of your cervix. So having heard that, I thought, this just really is a little bit so far beyond the reasonable realm that I got to address it. And when I addressed it, she said, well, why don't we just agree to disagree? So I figured, you know what, why don't we just educate people? And that way you'll actually know what's going on and have a better idea of, what things are available and what things are not available and which of them work and which of them doesn't. So I'm going to screen share. So we'll go through a couple of things. I have a paper, but I'm not going to reference the paper today. I'm just going to talk to you guys and write some stuff down so that you can see it. And hopefully, if you have questions along the way this time, let's make it interactive and you guys can ask as we go. And that way we can kind of learn and figure this stuff out together. So there's a couple of different things that work. So number one, you can do basal body temperature, which is just monitoring the temperature of your body. And it can be done intravaginally or just under your tongue. There's different ways to do it. There's urinary LH monitoring, which is where you can check for the breakdown product of LH in your urine and look for the LH surge, which is predictive of your ovulation. And then there's the cervical mucus. Cervix is always CX for us. And depending on whether you're in Canada or the US, you have an OUS or a US. And so some people use that to determine. And then there's what this article said, or this poster said, which was cervical position. I'm not even sure what the hell that means, but we're going to check it out anyways. I ran out of space. You see that? So the question is, which of these works and which of them doesn't? And, what can we do to try and improve all of this stuff? So basically what we decided to do was look at the research behind this to see what works and what doesn't. So we'll talk about basal body temperature first. So basal body temperature is based on the fact that around the time of your ovulation, and I'll flip back to a different thing here. Around the time of your ovulation, your basal body temperature, you can see it right here, is going to take a drop. So you can see right on this graph, and I'll kind of highlight it in red here, right here, you can see that, oh, is that not drawing for us? Yeah, right there. The drop in your temperature signifies the time when your LH is at its lowest. And so if you're monitoring, you're looking for an acute drop, usually around 1 degree roughly. But as you can see in the graph, it's actually not really a full degree. It's like decimal places. So up here at the beginning, you're looking at about a 36.45 degree. And then down here, it's only 36.15 or 175 or something like that. So, I mean, those are pretty small incremental changes. And because of this, although it can be predictive, the reality is that in 2005, a review article summarized all the data to that point and said, this is a useless test. Why? because it was only predictive in about 22% of cases. And because it's so poorly predictive, people said we really should not be using this. So can you determine your ovulation from this? Maybe, but is it really predictive? No, it's really not predictive. It doesn't help you because it's so finite. Now, if you're looking at a rise in temperature, yes, because as your progesterone levels go up, it drives up your body temperature, and that's what's happening over here. And now you're going up almost a full degree, but you've missed your ovulation. So now it's like a week later and it's way too late. So it's really not that useful a test. What kinds of things can affect it? Stress, your exercise habits, your weight, the time at which you do it, the number of blankets that were on you if you're doing it first thing in the morning, all sorts of different things, illness, fever, medications. There are many, many different things that can impact this. So basal body temperature, not a great selection. And so should we be using this? Realistically, no, we should not be using this. Get rid of basal body temperature. So then we look at doing the urinary LH. So is urinary LH predictive? Well, these are basically the pee sticks. So you pee on a stick and it'll tell you when. So depending on which kit you get, you can actually get about a 97% accuracy in predicting your ovulation. Do they always work? No. And the reason is that there are variations in the secretion of your LH, with some people being slow releasers, slow risers, some people being faster. And so because of that, not every LH kit will detect every patient's ovulation. Plus, there are some people that can have an LH surge and still not ovulate or be ovulating empty follicles, none of which you can predict with just the urinary kit. So is it accurate? Yes, 97% of the time, 97% of the time, it'll be accurate and you'll be able to detect your ovulation. But is it going to be universal where you get it every time for every person? No. So should we use it? Yeah, sure, we should, because it's a damn good tool. It's really easy to use. You don't have to measure your temperature every morning or worry about the confounding variables there. You just have to pee on a stick and it'll tell you yes or no. We know that normally speaking, somewhere between 36 to 42 hours after you've got a positive, you'll have your surge result in an ovulation. And so you have a reasonable timing frame to know when to have intercourse using this. What about cervical mucus? Well, cervical mucus does change based on the concentration of estrogen in your body, and there are changes that go along with it, including the consistency, whether it's sticky, whether it's not that sticky, whether it's stringy or not, the color and all of these things, which people use to kind of denote whether or not they are ovulating. So the problem with cervical mucus is, in one study, it showed only a 44% efficacy in detecting whether or not you're ovulating, where others had as high as about 75%. But realistically, again, it's difficult to do. There's a lot of confounding variables, especially if there's infection present. And not everybody is the same. So some women just naturally have much thicker mucus than other women do. So is this reliable? No. And do you really want to take only a 75% chance when you can get a 97% chance? So cervical mucus, usable, but does it make sense? No, it does not make sense. Skip doing the cervical mucus. It's not going to help you. And then the last one is cervical position. So the idea that this masterclass was offering was that by sticking your fingers in and assessing where the position of your cervix was, you would be able to tell whether or not you're ovulating. So this is total garbage. First of all, there's not a single study in existence, because I looked for one, and there's nothing out there. Number two, no one is capable of sticking their own fingers into their own vagina, which is difficult enough on its own, and then being able to tell the difference in the cervical position. As a gynecologist, all I do all day long is check cervixes or cervices, and it's still not possible to compare one time to another unless you really, really, really are attuned to what you're doing. So is this reliable? Of course it isn't. Any kind of thing inside you could impact this. Pressure, bloating, a full bowel will move your cervix backwards, forwards, further down, further up. A full bladder will alter the position of your cervix. So it's total garbage to think that someone could teach a master class on the position of your cervix in relation to whether or not you are going to succeed. So this one also is useless. So what does this leave us with? It leaves us with using the urinary LH kit. Are there any exceptions to this? We can stop the share. So yeah, there are. There are some new systems coming out with basal body temperature monitoring where you actually have to put some kind of probe inside your vagina where it can constantly check your temperature, and then it'll tell you. Why someone would want to do that instead of just peeing on a stick, I don't understand. But if it's really important to you to monitor your temperature, you may want to opt for those. They claim a 99% efficacy and sensitivity in detecting ovulation. Whether that's true or not, nobody knows yet. And again, there are going to be a lot of confounding variables in that. So whether or not you are feverish, whether or not you've recently been sick, did you exercise, did you just have sex, were you excited about having sex, anything like that will change your temperature. It'll cause stress, it'll cause alterations, and therefore it will throw off the results. So super important. If you see stuff on the internet, don't always believe it because it's on Instagram. Make sure you're getting scientifically validated data. It is not okay to just read stuff. And people are actually making money teaching classes, master class, on stuff that is absolute gibberish. So I feel terrible that I even have to do this. We shouldn't have to do this. People should be decent enough to know that what they're selling is just total nonsense. But apparently some people see an opportunity for money and they go for it when they really shouldn't be, because it's quite inhumane to do so. I will probably pick the topic of induction of labor next week, because last night I had a great episode where I found someone that was claiming that you should not be induced even if you've made it to 42 weeks of gestation, which nobody does anymore, by the way, because it wasn't necessary. And when I pointed out to that individual that the risk of stillbirth was massively increased, they said, no, it's not. And when I showed it to them with studies, they actually blocked me from being on their Instagram account. So I think I'll review that just so everybody knows the truth about induction labor and knows the safety of induction labor, because lots of people, once they're pregnant from our wonderful treatments, want to know, should they be induced or shouldn't they? And we actually encourage our patients to get induced at 39 weeks. And so I'll go through that data with you next week and explain it to you. So thank you for joining Fact or Fiction. Not so much fact or fiction as per se, but it is a fact that the urinary LH kit is very useful and you can use that, but the other ones really are not. So don't bother measuring your basal body temperature. Don't try checking your cervical mucus. And for the love of God, don't take a master class on cervical position, because there is no such thing. So we're going to take your questions. Were there any during the segment on that, or nothing on these ones? All right, fire away. All right, fire away.
I've had 2 failed FETs with untested 3BB embryos. 29, PCOS, MFI. I'm waiting for my period to do fertility. I have a day 5, 3BB, and day 6, 4BB left. After my testing, should I transfer both embryos?
It's unusual that you haven't succeeded already, and I'm sorry about that. If you mean, should you do both at the same time at your age, that's really questionable, because statistically speaking, you should succeed this time. And if you are going to succeed, you might succeed with 2, and now you have a high-risk pregnancy. So I'd still probably go with 1. A day 6 embryo that was, I think she said 4BB, is still a really good embryo. So I would not hesitate to do those one at a time. That's probably a very reasonable approach. I don't know if you're with us or not. If you are, I'm certainly happy to discuss it with you. But if you're not, you should be discussing with your RE, because we would normally encourage you to only do 1. Sometimes we'll do both, but normally we would do 1.
Hi, Dr. Victory. What is the treatment for a closed cervix? Any medication for that? What should I do to conceive in this situation? Thank you.
So cervical factor is a real deal. I mean, we deal with this all the time, and we check it and make note of it, both in our saline infusion sonohystogram, and then we make note of it in our initial review of the patient's fertility status, and we discuss their cervix with them. There's really only two options. One is to bypass the cervix by basically doing insemination or IVF, which is reasonable as long as you can get through the cervix with a catheter. And the other option is to dilate the cervix, which requires knocking you out and then stretching it open. I always tell my patients there's no guarantee it'll stay open. It kind of depends on what caused it to get closed in the first place. So if it's infection, previous surgery like a LEEP procedure, a loop electrosurgical excision procedure, if you've had scarring from some previous surgery or something like that, any of those could make the cervix very difficult to keep open. But in the absence of something like that, you've just naturally got a tighter cervix. Frequently, a dilation will help to open the cervix up, and then that should improve your chances. And we offer that to all of our patients with a tight cervix. So that's a very reasonable approach to things. IUI, IVF would also be top of the list for choices of things that you could do. So you really have the natural approach, which is stretch the cervix open and try it naturally, or you have the other approach, which is to actually do it with insemination or IVF. Yeah.
Hi, Dr. Victory. What? Hi, Dr. V. Hi, T. Oh,
T2.
Please direct me to the videos with the study information for HCG wash and uterine PRP.
Uterine PRP was a few weeks ago. Should I look it up on this? Yeah, I probably could. Let me see if I can find it. I don't remember where the uterine PRP one was, but I'll look it up. No, it was just recent. Yeah. That one was recent. I remember that one. You know what? Maybe I'll find it on this. Okay.
I can find it for her.
And send it?
Yeah, I can do it.
That one was recent. The HCG wash was
a long time ago, right?
That was like 2 years ago. That was a while back.
So HCG and age.
HCG and age was about 2 months ago.
Yeah, HCG and age. I have that one.
Let's see. Oh, fertility factor fiction. Okay, so let's look at all of those and I'll find it for you. Are these sequential?
Those should be in order, I think.
No, they're not. HCG and age is called HCG and age. Well, this will take a while. We'll have to look for it. Why don't we take her name down and then we'll send it to her.
Yeah.
I'll
do that.
Yeah, I'll look for it.
My RE suggested I may have PCOS based on a high follicle count and go in my first pregnancy. I have no other markers or symptoms of PCOS. Should I be on metformin for the embryo transfer?
It depends on if you're insulin resistant or not. If you're insulin resistant, you should definitely consider doing it. If you're not insulin resistant, it probably will not necessarily help you very much. And there is data to support that. So the only reason to do it is if you have insulin resistance. Now, if weight's an issue, then yes. But if you're a thin PCO, we don't normally use it for those patients.
Hi, Dr. V. How many days after consultation with you can we start protocol for IVF, considering we have completed all recommended testing and everything looks okay? I've heard that we need to see a naturopath a few months before starting IVF. Is that correct?
No, we definitely recommend involvement from our naturopath, but you don't have to by any means. So that's up to you. If you want to, you can. You can be ready in as soon as a month if there's no reason not to have you ready quickly. So that's up to you guys.
I have a message that says, hi, Dr. V.
Hi, Dr. V. Thank you for the friendly hellos. That's always nice. We like that.
Age 42,
okay.
Failed Euploid transfer. Do you recommend additional testing moving forward?
Age 42 failed euploid transfer, you have about a 40% chance of success. So if you have more euploid embryos, I'd probably try one more and then I'd start doing additional tests. Although I fully respect the fact that it's expensive and some people will want testing after just one. But at age 40, your chances are not as high as we would like them to be, even with a euploid embryo. And we just reviewed that on the show a little while ago. So yeah, I would probably want to look at the opportunity for testing, but it would very much depend on how many euploid embryos you have left. If you have like 5 or 6, then I would say no. If you only have 1 or 2, then yeah, I probably would do some testing first. That's a great question.
We are anticipating doing a transfer by the end of next month with you.
Oh, great.
Any suggestions to prepare my body?
Loads of suggestions. So lots of vitamins, daily exercise, low stress, meditation, yoga can be helpful. So the guys right next to us have yoga for fertility specifically. That can be really helpful. There are studies that show that it's beneficial. Acupuncture, very, very useful. Healthy diet, the Mediterranean diet is supposed to be best. And all of those things can help you get prepared. The rest of it we have to do for you, so you can't do too much. But healthy dieting, exercising, lowering your stress levels, no smoking, no drinking, no drug use, all of those are really critical.
My first birth was with you.
Oh, yay.
And an elective induction. Fantastic experience, short and manageable labor, no health issues with myself or baby, uncomplicated vaginal birth. Can't wait for next week.
Oh, fantastic. Yay. Yeah, I read this. It was a UK post where the woman put up a reel saying that people should ignore the guidelines that say that you should deliver before 42 weeks. And like no one delivers after 42 weeks, not even, the craziest patient out there would deliver after 42 weeks. The stillbirth risk is 700% higher. Even from 41 to 42, there's a 6-fold increase in the stillbirth risk. We're not talking about like minor things. And we know now that there is actually no difference in outcomes for C-section, asphyxia, hypertension, things like that in a negative sense. In fact, induction reduces those risks if you're being induced earlier. So they were trying to claim that waiting was better because of all these harms when none of those things were true. So that's why I'll talk about it next week and bring it to everyone's attention.
Hi, Dr. B. Do you believe an isthmusseal could cause infertility? Would it warrant a repair for unexplained infertility?
Yeah, for sure. If it's big enough that it's producing fluid or interfering with the development of your lining, yes, it will definitely, cause a problem. So if you have unexplained and you have a known isthmusseal, we would normally repair it.
ULH kit versus blood kits for IUI. Which would you recommend?
Urinary LH or blood test?
Mm-hmm.
Well, if it's convenient for you to get a blood test, then it's going to be even better than the LH prediction on the urinary kit. But if it's inconvenient, just use the urinary one. There's certainly nothing wrong with that whatsoever at all.
Hi, Dr. Bean Tarek. If NAC upsets my stomach, what will be the other option supplement? Thank you.
Well, it depends on what your issue is. So if you have endo, you can use resveratrol, NAC, coenzyme Q10, or curcumin. If you're using it for PCOS, you got coenzyme Q10, inositol, resveratrol, and NAC. So there are other supplements you can use as well.
Do you also do circumcisions for babies you deliver?
I do. Yeah, all the OBs in Windsor do circumcisions for their babies. I do them for my own. And I do them on the weekends for everybody because that's the rules that we have there. In reality, I used to do them in the office for a long time, but we've stopped that for several years now because the hospital came to its senses and brought the price down. I only moved it into my office because they were gouging people and I hated that. So, yep.
Are progesterone suppositories as effective as an injection?
No, and that's been proven. We've reviewed that on the show. It's actually called Progesterone. What is the most efficient way to use it? I'm looking at that video. So No, it's not as effective. If you want to use progesterone, you should be using both. All the studies support the fact that progesterone and oil with vaginal is better than just either one alone. But if you have to choose one, you want the oil, not the vaginal.
Experienced my second loss.
Oh, I'm sorry.
You were there in the OB triage, and I'll never forget how genuine and kind you were. Thank you.
Oh, thank you. That's very sweet. You know what? Pregnancy loss is a huge thing. No one should have to go through it, but it's unfortunately a very common biological reality. And my heart goes out to everyone that experiences a loss. So thank you for the kind words, but we're there for you, and we should be in every way possible. And I wish we could attend to people's needs more easily. I've been fighting with the hospital forever to be able to kind of immediately offer people management. They haven't come through. So actually yesterday we applied for privileges to start doing it here. So hopefully within a month or so, we will be able to accommodate people's needs in the office within 24 hours so that people don't have to wait any longer. So hopefully that'll be the case. We will let you all know.
Became pregnant second time after loss. Took metformin and baby aspirin.
Yep.
Progesterone suppository. When should we stop these? Thank you for all your guidance and answering all my Instagram messages.
Oh, no problem. Don't stop them until you have the baby, except for the progesterone. Progesterone you can stop at 36 weeks, but aspirin and metformin continue right through.
Hey there. I have unexplained infertility.
Okay.
Getting ready to transfer out last 2 embryos. Already had 3 transfers, but I have issues getting my lining past 6.8 using estrus. Any lining tips?
Viagra, PRP, platelet-rich plasma. You can try those. Vitamin E and D and C, especially vitamin E. It's been shown to thicken the lining. Baby aspirin. Try stimulation with letrozole. And then try different formulations of estrogen. So you may want to try vaginal if you're trying oral, or try transdermal if you're trying vaginal already. So there's different ways to try and deliver it. And sometimes people respond differently.
Hi, Dr. V. First, I would like to say thank you for being here. I really appreciate it.
Well, thank you.
Today, actually, my MD told me I have adenomyosis.
Okay.
Adenomyosis.
Yep.
She said with this, I would be harder to get pregnant. She suggested hormonal pills or IUD would help. She also said that she can refer me to a gynecologist. Should I wait until I see a gynecologist before taking these pills, hormonal pills?
So when they say hormonal pills, they're really talking about birth control. So the progesterone IUD or the Kylena or the Mirena, whatever you want to call them, they'll all be very effective for adenomyosis. Birth control pill would be reasonable. They're not as good as using the progesterone IUD because there's a direct local effect. But in terms of getting pregnant, it can be harder, but it isn't always. There's actually quite a substantial number of women that have adenomyosis and nothing ever comes of it. But if you have severe adeno, yes, it can interfere. So, I mean, I would probably talk to a gynecologist just because they need to know how severe you are, and then they can determine what your chances of, pregnancy are, and you may need to shift your timelines based on how hard it might be, because your adeno will get worse over time. So the only thing I would say is not every gynecologist will know the fertility impact of an adenomyosis diagnosis. So you may actually want to see one of us. So you might try and see a fertility specialist rather than just a general gynecologist, because they may not know all the details.
Hi, Dr. VNT. Wondering if you can go over the thrombophilia blood testing. Working with you after a loss at 16 weeks, my second pregnancy. My first pregnancy was uncomplicated carriage to term. I am Rh negative. Not sure if that would be any influence.
Well, Rh negative would be a problem if you are isoimmunized, meaning you've been exposed to the positive blood type and now you've mounted an immune response to it, because if the pregnancy is Rh positive, you will attack the pregnancy. So that's something very easy that can be tested by doing antibody testing for your Rh status. So it's an easy thing to do, and it's done routinely. In terms of your thrombophilia screen, there's a whole list, so I'll go through it reasonably quickly. Factor V Leiden would be the most common. Antithrombin 3 deficiency, prothrombin gene mutation 21010A, G210A. There's protein S deficiency, protein C deficiency. There's a lupus anticoagulant. There is antiphospholipid antibodies. And then there is the methyl tetrahydrofolate reductase enzyme mutation. So all of those can contribute to thrombophilia. I'm sure there are others, but those are the ones we always test for. And if you have those, you need either aspirin and heparin together in combination, or you need aspirin, heparin, and folinic acid or methylfolate, which is different from folic acid. And that's only for the methyl tetrahydrofolate reductase enzyme deficiency patients or anomaly patients. So there are a host of things that we look for. And if you have them, we treat you to thin your blood. If you don't have them, then obviously it's not a risk factor. We have had patients where we still treat them, even though they screen negative, because the history is suggestive of it. And obviously we don't know the full limits of science. So there are times where we will treat you, even though we don't actually know if it's the a thrombophilia that exists.
Dr. V, if endo is suspected, how long of a wait time is it for a lab to be done? Would you try IUI while waiting for a surgery?
Yeah.
It'll be long wait to get the lab done. I'm 40 this year, so feeling like time is running out.
I'm sorry that age is a factor for you. You're right. I'm not going to say your time is running out, but it is challenging. And the longer we wait, the shorter or the lower the chances. So a case like yours, we would probably try to expedite. Having said that, because of COVID right now, it is extraordinarily difficult to get people into the operating room in a timely fashion. So we're moving our hysteroscopies into the office to help alleviate some of the OR burden, which will leave me more time to do the laparoscopies in the hospital, but it's still challenging. So best case scenario, I would say several months, at least a couple of months. Worst case scenario for people that need something like a hysterectomy, we're looking at like 6 months to a year right now. So it depends on what's needed in your specific circumstances. And obviously we triage. If I've got a 25-year-old with unexplained and a 40-year-old with endo, we're going to have to do the 40-year-old first, right? So we do triage it and make decisions based on how urgent it is. But it's a mess because of COVID.
How long after I'm done breastfeeding baby number 1 can I come back for embryo transfer number 2?
6 weeks, 2 months. I mean, your prolactin level just needs to go down, and then you're good to go. And yay. You know, for some reason, when I clicked on fertility fact or fiction, it didn't have all of our videos. There's 70. I mean, we've got to have.
Yeah, we've got a lot.
There should be 200. Why is it only showing 70? I don't know. Maybe that's why.
Can't see the IUI one?
Maybe that's why we can't see the PRP one and stuff like that. You'll have to look at that.
I'll look at that.
Yeah. Yeah.
Hi, doctor.
Yeah.
I have endometriosis and fibroids.
Okay.
The 2 IVF, first one pregnant after 2 weeks, I had a miscarriage. Did another one a month after, failed. Do you have any suggestions for me?
So IUI, first one had a miscarriage. Second one, she had a fail.
IVF.
Oh, IVF.
Yeah.
First one had a miscarriage. Second one was a fail.
First one pregnant after 2 weeks.
Yeah.
Had a miscarriage. Did another one after fail. Yeah. Any suggestions?
Well, I need to know a lot more. I need to know all sorts of stuff about you, your age, your weight, your habits, your partner's age, weight, habits, what kind of cycle you had, how many embryos you made, what quality the embryos were, what protocol they used. I need tons of information. So if you're already our patient, call the office and we'll talk about it, which we already should have done. If you are not our patient, then call the office and get a consult and I'll help you figure out what's wrong. Something I seem to be doing more and more the more of these shows we do. So a large amount of my time now is spent helping people all over the world who are not getting optimal care where they are and they want answers. So they're contacting us saying, because we know the evidence, what works and what doesn't, and then we guide them through our process, and they all end up succeeding. So it's been pretty good. Yeah.
Dr. Victory, I'm not sure if you answered my question from last week.
Oh, okay. Fire away.
I'm 36-year-old and got my results for AMH.
Okay.
Right?
Yeah.
AMH level less than 5
Nanograms per mil or picomoles per liter?
OP moles per liter, I guess picomoles.
Picomoles per liter. Okay.
I has a 63% probability of an antral follicle count, AFC less than 8, AMH levels greater than 16.2 picomoles per liter. I have a 75% probability of AFC greater than 1.5. My results are 24.5. Will that be a good result?
That was super confusing. So if you're saying your AMH is 24.5, which I think is what's being said, then yeah, that's a great result. If you're saying something else, then I need to understand better what you're saying. But if you have a AMH level of 24.5, it at least indicates that your ovaries are either relatively or very strong. And so you can at least check off that box as not being a problem.
Okay.
I think that's what she's saying. She was kind of giving,
A lot of context.
well, she was giving context because the number she's reading is from a study where if your AMH is less than 5, you have a 63% chance of producing less than 8 eggs. So I think that's what she's saying, but I'm not 100% sure.
What's your experiences with fertility? What's your experience with fertility in patients with multiple failed FETs with untested embryos? Has it often led to success with the next one?
It has.
And are the recommendations mostly antibiotics, etc.?
It's always antibiotics and probiotics. In our experience, it does really help correct things. So we've had loads of patients. One of my favorite patients ever is had a loss, an unexplained loss at 23 weeks. And so we did the fertility testing on her. She came back positive for all sorts of stuff. We treated her, and she's 28, almost 29 weeks now, doing really well. And we've continued to monitor her and on and off of antibiotics, but she is doing great because we pre-treated her. So yeah, I am a believer in fertility. I think for our IVF patients, it actually works quite well. It also seems to work fairly well for the ones that have had recurrent losses. So I can't say there's strong evidence for it, but I'm a believer based on the results we've seen. And it's simple and easy and basically harmless. So.
Hi, Dr. V. Thank you for answering my previous question.
Okay.
About adenomyosis.
Yep.
I live in Chatham. Would Dr. Charles Ham deal with adenomyosis?
Dr. Ham's an excellent doctor. He knows his stuff very well. I don't know the extent to which he would know the association between infertility and adeno, but he probably does. So I would trust Dr. Ham totally. Yeah. And if you need more questions answered, just give us a buzz or shoot us a DM or something. But Dr. Ham's a really bright guy, and he knows this stuff inside out and backwards. So don't be surprised if you see a VRC branch with Dr. Ham involved in the near future, actually. So yeah, that's something we are working on for sure.
For failed IVF, now doing IUI, insurance covers 4. I'm 44, been trying since 42. Still producing 10 to 15 follicles. Tips for max results.
Stop doing IUI. So after 3 at your age, it's useless. There is no chance of success. We have that on one of our factor fictions. So you should be stopping at this point and switching to IVF. If you're 44 and you can make 12 to 15 follicles, you should be making, like doing IVF a couple of times because it'll still take you a couple of tries. And then you should produce enough embryos to have a positive outcome. I would not pursue more IUI. If you do still want to do more IUI, there's actually very little that's going to make a difference in your outcome. So, vitamins, healthy eating, healthy diet, good sperm quality, make sure there's no smoking, drinking, drug use. Like those things will make incremental changes. But keep in mind that your overall success rate is 19%. So even if we make like a, 2 or 3% difference in your chances, you're still overall after 3 cycles getting a 19% chance of having a baby. So it's not robust enough to support telling you to do crazy therapies or things like that, because your outcomes are going to be poor, especially at 44. It would be very, very, very difficult. Just to put it into perspective, the reason we choose 3 is from a Chinese study looking at close to 100,000 cycles, where they demonstrated that if you were over 38, more than 3 cycles was useless. But if you look at the European guidelines from ESHRE, that's the European Society of Hormones and Reproductive Endocrinology, they recommend 1 cycle of IUI over the age of 39 and then go directly to IVF. So they don't even advocate for doing 3. So we tell our patients the evidence, but keep in mind that the European guidelines are saying don't even bother, just jump into IVF. So at this stage, with you already having done 3, you'll find very few people supporting the concept that you do more.
Some good questions.
I think I found all of our videos.
Okay.
But they all just say fertility fact or fiction. We're going to need to find some new titles, man. Yeah.
What are they under?
They were actually under the popular downloads.
Oh, that's interesting.
Like a lot of them. But I mean, we still don't have all of it. Like some of them have gone into the ether because, we should have. Maybe
YouTube's out to get us.
We should have 200 videos by now.
There should be at least 1 a week, at least, because there's more.
Yeah. I think it says 270 videos, but maybe we need to reorganize a little. Yeah.
Okay. I've had 2 FETs of Euploid embryos.
Okay.
Both fails.
Oh.
The first one I hardly felt during transfer. Second transfer was a different physician and quite uncomfortable.
Oh.
Is it a bad sign for there to be pain?
Yes. So we know that if you're cramping, it drastically reduces your success rates. Way back, we did a video on elements of an embryo transfer that predict success, and cramping is a very negative. So if it's painful, it should be stopped. Now, why it's painful is a different question. I don't know. But depending on where they put it, how far they go, how difficult you are, how full your bladder is, all that stuff, it really makes a difference. Yeah. So if it's crampy, don't go ahead with it. Just say stop. Don't continue, because that's not going to work.
Hi, Dr. B. What are the reasons for ectopic pregnancies? What is the probability of it after we do a FET, and any way to avoid it, or any precautions to take after FET? Thank you.
Okay, so there's a great Instagram hashtag called Ectopic Pregnancies, like hashtag Ectopic Pregnancies. It's relatively new, but the person that's doing it is doing a very good job. And so you can check out that site. I highly encourage it because it's my daughter that's the person that's doing it. Nice. So yeah, little Jenny, she's got that one up and running. So ectopic pregnancies are mainly occurring as a result of damage to the fallopian tube. So that can be from inflammation, infection being the most common, endometriosis, previous surgery, or congenital defect. Possible sources in IVF are really bad luck, because we always put the embryo in the right place, but embryos do have, the ability to move. And if they move into the tube, then they're going to implant in the tube. So it's important not to go too far into the uterus when you're putting in the embryo. Our rate of ectopic with embryo transfer so far, I think, has been like maybe 1% or something like that. It's negligible, not even 1. I can remember maybe 2 cases in the whole history of our program, and we've done thousands. So I don't think that that's a major issue. There is nothing you can do as a patient. I mean, I wouldn't jump up and down after an embryo transfer, but short of doing something physically aggressive, there's no way you're going to alter your risk of an ectopic. So just take it easy and you'll be fine. And I don't mean like sit there, like this, not moving, just kind of take it easy and you'll be okay.
I've been getting really lightheaded and feel like I'm going to faint while just sitting in a chair. I'm just under 22 twos,
22 weeks?
2 WOS, TWOS, 22 TWOS.
Okay.
Okay, yeah. Is this normal? I do have HG and I am on the Declectin,
Oh.
Zorfan, and Metac.
So it's not normal to feel dizzy when you're sitting. You should probably be going to the hospital to get checked out. You're probably dehydrated from your hyperemesis. So no, that's not normal. Go get checked out, please.
Do sonal histograms show if someone has PCOS?
Yes. A saline infusion sonohistogram done properly includes an assessment of the ovaries, and we can look and see if your ovaries appear to have a PCOS pattern. Keep in mind, still to this day, the ultrasonographic characteristics of PCOS are not part of the diagnosis of PCOS. So we don't diagnose you based on what your ultrasound shows, but it is helpful in determining if a patient has it or not.
PCOS, trying to get my BMI down in prep for a IVF cycle.
Okay.
GFDF.
GFDF. Okay.
Yep. Low carb and 3 to 4 times gym a week.
Oh, gluten-free diet.
Dairy-free.
Gluten-free, dairy-free. Okay, yeah. All right.
That's good.
That was good. Yeah. And then what was the rest of it?
Gluten-free, dairy-free, low carb, 3 to 4 times gym a week.
Okay.
Closer better, but scale won't budge.
Oh.
Afraid doc will turn me away. Any tips?
So it's really important that you get leaner. Your weight won't necessarily change. So if you're building muscle, remember that muscle is quite dense. And so it actually weighs more than adipose tissue does. So as you're losing adipose tissue, the fat tissue, and you're building muscle, your weight can actually even go up, but you will get leaner. So it's your leanness that's important. It's not necessarily your weight. Having said that, 3 to 4 times a week is probably insufficient, and the type of exercise you do is critical. So remember to build muscle, because that's what you want to do, because the more muscle you build, the more energy it takes to maintain the muscle. And if you don't take in enough energy by specifically calorie restricting, your body actually starts to resorb your fat supply in order to use that for energy, and that's how you get leaner. So build muscle. So make sure you're doing lots of weights, less cardio, and that will help you get to where you need to go.
Can you talk about why some FS don't include progesterone in
fertility specialists?
You can't do this without, man.
No fertility specialist who knows what they're doing would not include progesterone. There are innumerable studies that demonstrate that you must use progesterone in order to get a better outcome. So if you know what you're doing, you're using progesterone, plain and simple. Anybody that wants to debate that, please provide me with evidence that the success rates are the same when you're not using progesterone, because there is no such evidence.
Hi, Dr. VNT. Heading into FET2, BMI less than 35, however healthy, working out daily, cardio and weightlifting. With a higher BMI, what are my chances for this transfer to work? 27 PCOS, otherwise healthy.
BMI is 35?
Less than 35.
27 PCOS, BMI is less than 35. You're at about a 40% decrease compared to normal for whatever your center's normal is. So let's say if you're 27, I mean, we'd be looking at like an 80% success. So you'd be more like 50 with us. If you're somewhere that only has a 50% success, you're looking at a 30% success. So it depends on what the rate is.
I'm taking sertraline for anxiety. Are there any interactions with common...
Citrulline? Cipralex?
I'm taking sertraline.
Sertraline. Oh, okay. Yeah.
For anxiety.
Yeah.
Are there any interactions with common fertility meds, i.e. letrozole, progesterone?
Not that we know of. It can elevate your prolactin levels, and it's not great for pregnancy. But if you have to be on it, you have to be on it. Your mental health is really important. So We always encourage our patients to see if there is something else that they can turn to, but if there's nothing else they can turn to, then that's what you use. Oh, and happy birthday to my mom. Everybody wish my mom a happy birthday. Love you, Mom.
Birthday.
I do everything I do because you were the best example ever. So happy birthday to Genius Victory. Yeah.
Can you do a transfer while breastfeeding?
Can I? Yes. Would I? Absolutely not. Breastfeeding is going to jack up your prolactin levels, and a high prolactin level will suppress your estrogen. And the milieu is actually relatively anti-fertility. So breastfeeding is reasonably decent natural birth control. So why anyone would try that is beyond me. So no, I would never agree to that. I wouldn't. Maybe someone would, but I wouldn't do that.
Question I've never in my life seen or heard of.
You got a smile on Tarek's face. All right, fire away. I'm good.
Is lightning crotch a real thing?
Yes.
If so, what to do to relieve the pains?
So lightning crotch is typically the sensation of little electrical shocks that go up your cervix through your vagina into your uterus. And it's typically when your cervix is opening. So if it's early in your pregnancy, you should go get checked out. If it is near the end of your pregnancy, it's supposed to happen in Tylenol and rest and things like the warm bath, but there's nothing you can do. It's natural. But if it's early in your pregnancy, you're prior to 37 weeks, you need to go get looked at. Lightning crotch.
Lightning crotch.
You didn't know about lightning crotch?
I did not.
Bzzz.
That's what I was wondering.
Yeah.
Hi, Dr. Victory.
Hello.
How long is the waiting list to get in a consultation with you?
I have no idea, and I've been sworn to never answer that question. But depending on the urgency, message me, and I will always do my best. I have a lady whose ovaries are failing, and I saw her like the next day. So it depends on what's going on, but just contact us. And if you can't get through in a reasonable period of time, plead your case for why you need to be seen sooner, and we'll address it for sure. Usually it's anywhere from days to weeks to a couple of months. Never more than a couple of months.
Tuesday seems good.
Tuesday's good, eh? It's busy. You like the Tuesday.
See if they like it, remind them.
Yeah. Does everybody like Tuesdays? Thumbs up if you like Tuesdays. Thumbs down if you don't like Tuesdays. But Tuesday seems to work for us. Tark and I love our sushi, so that was actually good tonight. Although I didn't love the crunchy roll. The super crunchy roll was okay. It was okay. It was, it was okay. It wasn't the greatest. Yeah.
For FET, is it better to trigger with Overdrill or just monitor ovulations? If my progesterone levels are ideal naturally around 60, should I supplement with progesterone? You
should still supplement with progesterone, but don't overdo it because you can go too high. There is no benefit to triggering with Overdrill. That's been well studied. There is no change in outcome, so you don't need to do that.
Interested in tubal reversal. What's the timeline and process?
I just did 2 on Sunday. I wish you'd told me. We could have made it 3. So timeline, we got to do your testing and your partner's testing. So I make sure I'm not wasting your time or your money. And then if everything looks good, within a couple of months, we can get you in. We do them in a surgery center in Toronto called Clinic 360. I got to wear these glasses, which made me feel like I was breaking my nose. They're so heavy because they've got like the microscope is like a mini pair of binoculars. You've seen them, right? Yeah. So we got to wear those for like an hour and a half while I'm craning my head to see what I'm doing. But it's very doable. I literally just did 2 on Sunday. So usually we'll squeeze you in and I'll get them done. We just have to do your testing first.
Interested in tubal reversal.
That was the one you just read.
Oh, okay. Somehow I didn't recognize. Do you have any IVF specialist referrals in Connecticut?
Connecticut? Not that I know of off the top of my head. If you're going to the US, I do have some favorites. people that I really trust. I don't want to broadcast that out here. So why don't you just DM me and I'll tell you, but I don't know anyone in Connecticut. Having said that, because we're right across the border from Detroit, most of our US patients just come to see us. We monitor you where you are and you just show up here for your retrieval and transfer. It's cheaper and you end up doing better. So, that seems to be a very popular thing these days because our US practice is huge. So yeah, just drop by and let me know and I'll be happy to do your consult. And then based on what's going on, I can tell you where to go and how to figure it out.
People had asked me to go to Connecticut to perform, but I said I don't have my license in America.
Oh, there you go. I am also not licensed in Connecticut, so you're in good company. Utah and Michigan, and I'm halfway through to being done in California.
State by state, or?
Yeah, it's state by state. Yeah, like I'm eligible for licensure anywhere, but like it's painful. Like
Really?
the California one, oh my God, it was a nightmare. Yeah, I'm still not finished. I don't even know why I'm getting it. It's a waste of time.
So we can go to Cali.
So we can go to Cali.
Yeah. I'm going to be transferring my last 2 embryos before doing another retrieval.
Okay.
Since I know my odds are high of a second stim cycle,
Okay.
should I continue CoQ10 even while just doing FETs?
Yep.
If so, what dose?
600 a day unless you're using Neo Q10 from Theralogics. Yeah, I think it's called Theralogics. So that one you just use 125, but everybody else it's 600 a day. And yes, you should continue because it's harmless to getting pregnant, but it will affect your egg quality if you're off of it for a longer period of time.
Thanks for answering my previous question. Is there any way to help increase the chances of success with IUI that I can do?
Same things I mentioned earlier. I mean, eat healthy, make sure your weight is down, make sure you and your partner are not smoking, drinking, using drugs, including marijuana. Have him ejaculate frequently every day or every other day. Make sure it's in you because it primes your uterus, which we know now is beneficial for getting pregnant. Lots of vitamins, vitamin D in particular, lots of supplements depending on what your condition is. There are different supplements that'll work. Anything you can do to stay calm and de-stress will be helpful. Time it right. So you want to have sex basically frequently around your ovulation and then still frequently a little bit more distant from your ovulation. So I usually say every day or every other day up to ovulation and then every day for several days and then then go back to every day or every other day after that. So those are like the basic things. They will all help. As far as the IUI itself is concerned, we use Zymo for our patients that need it because it can be beneficial and helpful. Double IUI does not work. It's never been shown to be beneficial, so we don't encourage doing that. Aside from that, there's not really a lot more that you can do. Progesterone afterwards, baby aspirin, melatonin, like I said, lots of supplements, that kind of thing can help.
Hi, Dr. V. For an FET, is it better to trigger with Overdrill or just monitor ovulations? Also, if my progesterone levels are ideal...
She already asked that one. They're sneaky, eh? Yeah, I answered that one.
Is there any research out there to suggest cutting out dairy helps chances of conceiving? Each time I have conceived, I have been dairy free.
Yeah.
Not sure if it's a coincidence or actually helps.
A coincidence? There is some evidence. Boy, I'm going to piss off the dairy market. Cow people are going to be pissed. There is some evidence that eliminating dairy can improve fertility, but it's not good evidence. And it depends on patient to patient. So do I tell people to cut out dairy? Never. Will the naturopath tell you to cut out dairy? Almost always. So I'm going to leave that one up to my beloved Jen Strong or Laura Jasmine, who, if they're watching, can chime in. I don't tell people to restrict their diet, just smoking, drinking, drug use, high sugar, high cholesterol. But dairy can be pro-inflammatory. So removing or minimizing dairy can be beneficial for you.
I recommend ice cream.
You recommend ice cream, do you? So for new Persian New Year's was March 21st, and for New Year's our son was coming home, our oldest, so we wanted to make it special for him, and he loves this one flavor, which I also love, of ice cream called German chocolate cake from Baskin Robbins. It's the best, right? I know. It's got the nuts and the fudge and the caramel and the coconut and chocolate. It's amazing. Okay, so you can't get it. It's not available because they only bring it in season. So the guy goes, if you want it, you need to buy a full tub of the thing. I said, well, like the whole tub, right? I'm like, I'm not gonna eat a whole tub of ice cream, man. The thing's like, you're feeding like 50 people out of that thing. So he said, well, do you want a half tub? And I'm like, oh, all right, half tub it is. So I currently have, I got a half tub of ice cream.
Now I know what our friendship stands. Half tub of ice cream, no invite.
You are welcome, man. I'm getting obese finishing this thing. Oh, craziness.
901 for the record.
Tarek's terminal question.
Oh,
Pick
I
your
want to start with the one that says Ola.
Hola. All right, hola.
Hola, Dr. V&T. Oh, this is a great one to pick. Just went through a lap surgery and hysteroscopy. My doctor removed a hemorrhagic cyst on my
hemorrhagic
cyst on my right ovary and moderate endo.
Okay.
Also removed a uterine polyp and scar tissue.
Okay.
His advice was to try 2 natural cycles, and after that, if there is no pregnancy, we should start with medicated cycles. I'm soon to be 39. What is your advice? Thanks for your time and advice. Happy birthday to your mom.
Oh, thank you.
Today.
What a way to go, man. That was a good one. Okay, so we go right to IVF. That's a no-brainer. So medicated cycles are going to jack up your estrogen and just make your endo come back. And your hemorrhagic cyst was actually probably an endometrioma. You might want to look at your pathology, which means we're actually stimulating your chances of getting more endometriomas. You're in the best shape you're going to be in right now. So I would do your IVF. I would make your embryos. I would get them PGT tested. Once you've done the PGT testing, I would go ahead and do the suppression for 3 months with Lupron and Letrozole, all the endo supplements, resveratrol, coenzyme Q10, curcumin, NAC. Then go for a very low estrogen embryo transfer and go from there and pray for success, assuming you have genetically normal embryos. Great question. We're done? All right. Well, thank you for joining us for Fertility Fact or Fiction. I am apologetic that we cannot get through everybody's questions, but we do keep trying. I have not had time to do all the answers to the ones from last week, but I am going to do them probably tomorrow night. So stay tuned. We'll have like 50 million reels and maybe like a long YouTube video that we string together with the answers to everybody's questions. Have a great night. Thank you for wishing my mom a happy birthday. Big happy birthday to my mom. And we'll see you again next Tuesday on Fertility Fact or Fiction. We still need music, you know.
You know, people are